and its function, so I'm going to turn the floor over to her. Please join me in welcoming her to our conference.
Thank you. Okay, well, so thanks for the introduction and for the invitation. It's a pleasure to be here, and I hope you, if you're coming in from out of town, I hope you enjoy Cincinnati. If you just go over the river, there's a neat park that has been added in the last year, and it's just beautiful. We're down there with my family called Smale Park, so go check it out. There's lots for little ones and big ones to do. There's a big kid park for anybody older than 8, which included me, probably even over 5. And then there's a really little top park too, so get your kids over there. It's called Smale Park, and it's right between the 2 coliseums, where the Reds play and where the Bengals play. All right, that's my little advertisement for Cincinnati. Today, Dr. Ware and Nietzsche asked me to come and talk to you about the immune system. So I'll tell you a little bit about myself first and why Dr. Ware recommended that I come. And then we'll dive into talking about the immune system and the charge that I was given about how to talk about the immune system. And I'll give a little disclaimer that I have a little something for everyone. So what I've noticed in talking with families is that there are some families who are extremely savvy, and when you show up to give a talk, they know more than you do, which is awesome. So there will be some slides that will be directed, detailed, and as if I were talking to physicians, because I found that some families are that sophisticated. And those are the minority of the slides, but they are there. So if you think this is way too simple for me, I hope that I can reach you in terms of a more complex topic. And then for those of you who don't want any complexity, I'm hoping to make it as simple as possible too. And so if there are kids in the crowd, they are free to ask questions also, because nobody is smarter than a 5th grader, right? And maybe even a 4th grader and a 3rd grader. I have rising 9th graders, and they are definitely smarter than I am. So feel free to have the kids ask questions too if they want to. So, all right, and feel free to stop me as well. So I have been at Cincinnati Children's for since 1997 when I did my pediatric residency here. I see a lot of growth in the hospital, and I did a fellowship, did pediatrics residency, and then a fellowship in allergy and immunology, and then really focused my energy on learning about the immunology side of things, although I also wear a hat of being an allergist. That's not what we're going to talk about today. So I see patients within an immune deficiency clinic, and ironically, the majority of my patients are not asplenic. I think part of the reason for that is that your cardiologists do a very good job of making recommendations for your children who have either polysplenia or asplenia. So I'm just going to call that asplenia from now on. I don't want to make you think that if there's a polyasplenia parent or child with that, then I'm eliminating your child. I'm not. I'm just going to use the term functional asplenia, okay? So, and I think our cardiologists do a very nice job, but there are times when I do get involved, and generally it's to look at the rest of the immune system in children who have had infections, to make sure that the rest of the immune system is intact. And in doing so, then I've gotten to know a little bit about asplenia as well, because the vast majority of my patients, as I said, don't have asplenia, but they may have surrogates for asplenia that overlap with your children as well. And so I'll talk a little bit about that as I go. All right, so I've been seeing patients now on faculty for 10 years, and as I said, my clinical expertise is as a clinical immunologist. So these were the questions that were emailed to me directly from Nietzsche. So first, to briefly explain the spleen, how it works, and what tests can be done to assess its function. And 2, to directly address sepsis, what it is, early signs and symptoms, urgency of care, and steps families can do to reduce risks. And then if there's something that isn't up there that you're burning to ask about, we'll save those questions at the end, but feel free to ask me either directly where. I do think it's helpful to ask in front of everybody because maybe other people are just too shy to ask the same question. All right, so what is the spleen? I know you guys spent a lot of energy in the first few years thinking about the heart. So this is below the diaphragm, and so you can see, let me see if I have, this is a pointer, yeah. So this is a picture I took off the internet where it shows how I think about, you know, heterotaxy syndrome. I think about this little organ tucked away back there and whether it's there or not, right? So the energy is not directed towards which direction the heart is facing and whether the liver is in the middle or to the right or to the left, but is that spleen there? This is a picture by a famous cartoonist who's taught everybody anatomy, who's gone to medical school. And it's just a picture showing the blood vessels coming into the spleen and the blood vessel coming out of the spleen. And what you notice is that it's red. And that was done on purpose because and we'll talk a lot about this, so the spleen is an immune organ that filters the blood. And so there's a lot of blood in there. And so we're going to talk a little bit about how it's an immune organ, a little bit different from lymph nodes. Lymph nodes, if you pull them out, we wouldn't make them red, we'd make them white, okay? So red means that there's a lot of blood flow. In fact, all of your body's blood goes through the spleen. So the spleen sees essentially all of your blood within a half an hour. So every half hour, my spleen is seeing something new that it hasn't seen before, but everything gets through within a half hour. So it's really very efficient at monitoring the blood for pathogens, meaning bacteria. So what is the spleen? So here's my simplest of terms, okay? So the spleen is two things. It is an immune factory, like a lymph node is, and it's also a garbage disposal. So immune factory and garbage disposal. So what is an immune factory? An immune factory is just some place where you generate immunity, and immunity means your ability to prevent infection and fight infection, and then to remember infection. So the immune system's job is to recognize infection, to fight it off when it's there, and then to remember it so that the next time you see that same pathogen, you can fight it off faster and prevent it from becoming a serious infection. So the immune system does this by generating immune or white blood cells to fight off infection. And there's two primary cells. There's B cells and T cells. And the spleen is able to generate mature B cells and mature T cells to fight off infection. So here's the complicated part. This is a figure that we use in our teaching of our fellows. And so if you're more interested in complexity, this is it. If you're not, shut your brain off. Just remember garbage disposal and immune factory. So this is, there's something for everybody here. All right, so this is my crash course in immune cells, B cells and T cells. Those cells are also just called generally lymphocytes. So you may have seen on a complete blood count an absolute lymphocyte count or percent lymph. Those are B cells and T cells when you're looking at a peripheral blood, complete blood count. All right, so first thing you have to do to generate B cells and T cells is you have to have some sort of primary organ that grows them from when they're babies. So they are babies, they generate in the bone marrow if you're a B cell, and in the T cells they generate in the thymus, which is an organ that sits in front of the heart. The B cells go on to, and T cells, both exit out of their generative primary lymphoid organs to go into the blood and eventually into the peripheral lymph tissue, the peripheral immune factories. These are the immune factories. So here we have lymph nodes, but here's our friend the spleen. And then there's also lymph tissue in various organs. So for example, in your stomach, you can't see them, but there's lymph tissue in your stomach as well. And there's lymph tissue in your lungs, as well as there being lymph nodes that you can feel here in tonsils and adenoids. Those are all secondary lymph tissue. Those are immune factories. So here's the spleen put in there right with all the others. And I show this just to show you that in terms of immune factories, you can see already there's backup here, right? The spleen is not the exclusive organ for generating mature B and T cells. So that's good news for us because we have lymph nodes in our neck, we have lymph nodes in the organs that we're worried about. All right, so what do those T cells and B cells do when they get there? They generate proteins called immune globulins. IgM and IgG are two of them. Another one is IgA. Those proteins are special. They circulate in your blood and they fight against both viruses and bacteria. And for the purpose of today's talk, we're going to be talking mostly about bacteria. And the B cells and the T cells have to work together to make those antibodies, those proteins, in order to fight infection. So the immune globulins, IgG, M, and A, they're made by the B cells. They have to get help from T cells. They generate these proteins in order to bind to bacteria. So the proteins themselves will do a couple of things. First thing it does is it targets them for elimination. So if a protein binds to a bacteria, it actually tells other organs, in particular the spleen, the garbage factory, or the garbage disposal part of the spleen, it tells them, get rid of this guy. This guy's no good. So it recognizes that that protein will bind to a bacteria, and it causes recognition by the immune system because it has the IgG sitting on it. The second thing that an antibody will do is prevent the bacteria from entering into the tissue. So say you get strep pneumo in your blood, you don't want it to go into your central nervous system, to become meningitis. You don't want it to go into your lungs to become pneumonia. You don't want it to go into your bones to become a bone infection. So the antibodies prevent the bacteria from entering that, because the antibodies can be directed against the part of the bacteria that tries to invade into those tissues. So it can prevent access, and therefore you can have more time to eliminate that bacteria. So you can both block, we call that neutralizing antibodies, something that neutralizes the pathogen, prevents it from ever infecting the tissues. So the spleen is particularly good at generating B cells. For one reason, it's big, right? In proportion to the little bitty lymph nodes that you have in your neck, the spleen is quite large as an immune organ, although most of it is the garbage factory, the garbage disposal function that makes it that big, all that blood entering it as well. But it's particularly good at generating antibodies against problematic bacteria. And the problematic bacteria historically related to functional asplenia have been Streptococcus pneumoniae, Haemophilus influenza B, and for asplenic patients, so splenectomized patients, not functional asplenia, meningococcus. And the reason why I mention that is we lump them all together, but in reality, when you review papers that talk about children with functional asplenia who are born with asplenia or polysplenia as part of heterotaxy, meningococcus is not really what you read about the most. It's actually strep pneumo and Haemophilus influenza B, and that has changed over time. And we'll talk a little bit about the details of that. All right, so what does vaccination do? Well, it tricks your immune system to get ahead of the bacteria. So if you give a vaccine, you then trigger those B cells to make that neutralizing antibody. To make that antibody ahead of time that's going to recognize that and target for elimination. If you don't have a vaccine ahead of time, then the body can't respond very fast to that bacteria. So that's why we vaccinate. We try and get ahead of the game by giving patients functional B cells that already recognize Streptococcus pneumonia, proteins that already recognize Streptococcus pneumonia. That's the whole point of vaccination. But those problematic bacteria were tricky, so they are special. And the reason why they are special, hopefully I guess I put it subsequently, is that the problematic bacteria, their surface is coated with a capsule to try and evade your immune system. So bacteria, evolve over time, and they try and escape our immune system because they want to survive. So the bacteria that are problematic in asplenia are bacteria that have a sugar capsule. So just as too much sugar isn't good for kids, it's not too good for our immune system either if the bacteria are coated with sugar, because in particular sugar-coated bacteria are not recognized by young children. So kids less than 2 years of age, their immune system is not quite mature enough to respond to sugar-coated bacteria. So people much smarter than I recognize that children, whether they had a functional spleen or not a functional spleen, were at risk from really severe infections, meningitis, pneumonia, when they were in this very vulnerable period, regardless of whether they had a spleen or not, between 0 and 2 years of age, because their B cells weren't as good as recognizing sugar-based bacteria. Smart vaccinologists developed vaccines that tricked the immune system, that took an immune system that wasn't ready to recognize sugar-coated bacteria and tricked them into making the vaccine tricked them into making an antibody against both a sugar and a protein. So I'm going to talk a little bit about those just so that you understand why the recommendations are what they are, particularly for strep pneumo vaccination. So sugar-based vaccine, I've got it backwards. That's funny. So this is exactly backwards than what I just told you. The sugar-based vaccine is Pneumovax, and the protein-based vaccine is the Prevnar. Okay, so we'll switch those. That's why we don't send out the slides the first time around. So Pneumovax was the first sugar-based vaccine we had. It was never indicated for kids less than 2 years of age because they can't respond to a sugar-based vaccine. They can't respond to a sugar-based bacteria. So then they got smarter and they developed Prevnar. First they developed Prevnar 7 and then they developed Prevnar 13, and currently that's what we have recommended. Prevnar 13 is recommended for itty-bitty babies. You get 3 doses of it as an itty-bitty baby, and that is a sugar plus a protein, and your body at less than 2 years can still respond to that. So that's neat. We trick our immune system into responding something that it wouldn't have any ability to do so. The first protein-based, or it's called a conjugate vaccine, it's both protein and sugar together. So the first one we had was Haemophilus influenza B. It was a game change for kids with or without a spleen. And it allowed children to no longer die from severe epiglottitis and tracheitis. That was a major concern with Haemophilus influenza B. And pneumonia, life-threatening pneumonias went down as well. And then because it was so successful, they developed Prevnar against strep pneumo, another type of bacteria also coated by sugars. And so initially they had 7 different strep pneumo, that was Prevnar 7, and now there's 13 different strep pneumos that vaccine is related to. And so sometimes if your children were born and they only got Prevnar 7, you could go and say, hey, is there any indication to do Prevnar 13? And my answer would be absolutely there is, because you were never vaccinated against those 6 other serotypes. So, all right. So the B cells, and one more plug for vaccination, and this is going to be the reason why I make recommendations for influenza vaccines, is that B cells in the spleen, as well as other immune-generating organs such as the lymph nodes, they also neutralize viruses. So why we recommend flu vaccination is that if you get influenza, you're much more likely to get a secondary bacterial infection, and so we don't want you to have bad influenza. So we try and prevent the viral infection. But that's universal for all children that we would recommend influenza vaccination. But this group is not, you are part of that group as well, and particularly important. So, all right. Second part of the spleen is a garbage disposal. So garbage disposal comes from a different type of white blood cell called a macrophage, and its job is just to gobble up dead stuff and gobble up bacteria and eliminate it. So it's a great garbage disposal cell, white blood cell. It clears debris from the blood, so dead cells found in the blood, red blood cells, platelets, even dead, dying white blood cells. It also gets rid of dead bacteria, but in particular why it's important to you guys is that it will eliminate live bacteria in the blood. So if you have that IgG that's coating that bacteria but it's not dead yet, the macrophages in the blood, in the spleen, recognize that antibody-coated live bacteria and they trap it and they allow that bacteria to die. They kill it. This is just a picture of a beautiful diagram of the blood coming in. Some T cells are here, some B cells are here, and then the macrophages really line this marginal sinus area. And then because they're surveying the blood, it's very efficient. So again, how is the spleen different from lymph nodes? So lymph nodes don't have a garbage disposal. All they do is survey for bacteria and they generate IgG and white blood cells, mature B cells, and T cells. And in particular, lymph nodes also are getting information from tissues. So if I have a sore throat, we feel our lymph nodes grow in our neck, right? Our spleen doesn't generally get bigger unless we have mono. That's an unusual situation. But it's really local, right? Most of our immune system is fighting locally. So all the T and B cells work locally in the lymph nodes that drain my throat. So the lymph tissue delivers the immune cells to the lymph nodes. So the spleen is special in that it is immune factory, yes, but the information and all the cells come through the blood. And so it's much more efficient than just surveying the sore throat at my level of my tonsils and the lymph nodes in my neck. Okay, so the immune factory to make antibodies and the garbage disposal to capture the bacteria. Any questions here? Immune factory and garbage disposal, we can get that. All right, so what tests can be done to assess its function? So in terms of, you can say whether it's there, okay? So you can do some imaging, and that's typically done in the first day of life, and ultrasound can be done. You may have a CAT scan for another reason. There's also a nuclear scan that will take advantage of the garbage disposal capacity of the spleen. So if you inject a particular, we call it a colloid, but it's basically something that the body recognizes and is taken up by macrophages. It'll go in and light up the spleen, and we take a picture of it. It's called a liver scan usually, because the liver also has garbage disposal function. And so it'll light up both the liver and the spleen. I'm doing it backwards. Did you see that? In honor of all of you, I said liver. Isn't that great? And he laughed, so that was perfect. So it'll light up both the liver and the spleen if you have a spleen. All it really measures when it doesn't light up the spleen is whether the blood is going to a spleen. So it's going to tell you it's a presence. Is it there or is it not there? Talks a little bit about its function as well. But there are better functional tests. So the functional tests that we typically look at are two things present in the blood. Because the garbage disposal function of the spleen is designed to eliminate dead red blood cells, dead platelets, dead white blood cells, we can look at those cells. Well, most of the cells that are made up in the blood are actually red blood cells. So it's easiest just to look at the highest frequency blood cells, which are red blood cells. And we look for something called a Howell-Jolly body. You may have seen that. It's hard to say, so I'm going to say HJ from now on. And they also look for, we can do a specialized test where we look in particular at a different type of smear for some similar membrane changes on the red cell, and it's called a PIT test. I know some of you are familiar with that in the room. In terms of assessing function of the immune factory, that's hard, right? Because first of all, I just told you it's not exclusive to the spleen. And second of all, so when you do an immune evaluation, a global immune evaluation, you're not really focusing on the spleen, but you can look at the entire, immune function, and sometimes that is important. So if a child has more infections than we would expect, we would look maybe at the total immune globulins and find out, well, why are they having more infections? Is it because actually their lymph nodes aren't doing a great job making immune globulin either? Sometimes that happens. And it's got nothing to do with the spleen in particular being down, but just globally things are not working. Okay, so I'm going to just give you a couple different cases of just children who I've evaluated and the difference. And I'm not saying any of these are right or wrong. It's just how some kids get evaluated. Most of it's done before they get to me. So this is just information pulled from the chart. So the first one is a 2-year-old who had an ultrasound at birth that showed no spleen, a CT scan later that showed no spleen. Ironically, the CT scan report initially said there was a spleen, and then the radiologist went back and said, oh, whoops, I should have written that there was no spleen. So when you're in my chart and you see stuff like that, please bring it to the attention of your primary care doctor just to make sure, because everybody makes mistakes. And so later we did a PIT count, and it was elevated. You can see that our ranges for PIT count actually at our institution are quite low. And so this wasn't very high. And so I was kind of wondering why it was not so high. We really expected it to be a little bit greater than that. But in the peripheral smear, there were Hal-Gel HJ bodies listed as well. And so clearly this child has functional asplenia. There's another one, had an ultrasound at birth, no spleen. At day 1, a liver scan was done. This is this colloid that's radioactive that gets injected, and the liver lit up and the spleen wasn't there. Had a PIT count at 2 years of age, also at our institution. You can see that was a little higher. And interestingly, peripheral smears, they didn't report HJ bodies. Now, part of that may be because a peripheral smear may have never been looked at by a human. So when we do white blood cell and red blood cell counts, a complete blood count, it's automated, goes through a machine. And so unless there's something abnormal about the smear, it doesn't get flagged for a peripheral smear evaluation by a human. So it may be that those are there, but it just nobody laid eyes on it. So I just let you guys know this so you have more knowledge as you think about the labs that are getting ordered on your child. So, but that a human always can look at it, and so then that's what we ask the lab to do. We'll ask pathology, can you pull that smear and make an actual physical smear rather than just the machine, and have a pathologist or a hematologist look at it for us. All right, and then a third patient, never to leave polysplenia out. I have a 5-year-old that I follow who has polysplenia in the setting of biliary atresia. Of course, they found the polysplenia when they went in to fix the biliary atresia because they were going into the abdomen for a surgical approach. He was quite young. His peripheral smears don't show HJ bodies. I've never ordered a PIT test on him. Part of it is that he was having recurrent infections, and he came to me with concerns for low IgG. So he's got bigger problems, but these things do happen. So he's on both prophylaxis for the presumed functional, there's functional asplenia, as well as he's on immune globulin replacement. Although I think we're going to take him off because he's doing better. All right, so I've talked about the spleen, how it works, and what tests can be done to assess function. So I'm going to move on, unless you have questions here. Yeah?
So we have had some cases, and so perhaps, I don't know if you have much information on this, but it's kind of, it's happening a little bit more frequently we see, is that there are families that are finding that they're, with heterotaxy syndrome, they're having one spleen and sometimes even normally placed. However, sometimes we see that these still are not functioning fully. So what are your recommendations for a person that, or a child that is identified with heterotaxy syndrome, has one spleen?
Yeah.
Still having that?
Yeah, I think it's helpful to ask that question of who's ever following you. And then that's where simple smears can be helpful, right? Because they can look for HJ bodies. They can look for, do things like PIT testing. Depending on the age of child, it may have an impact on whether they prescribe antibiotic prophylaxis, which we'll get into later. So there's other simple things that can be done. In that situation, I don't think that an M scan is going to be all that helpful. A radioactive scan is not going to be all that helpful because there's likely, if you have a spleen there's likely blood flow. Whether it works as a garbage disposal, I don't know. So I guess you could argue, well, if it takes stuff up, then it's probably working well. You could probably do a combination of things there. But it's interesting that you brought that up, because just because a spleen is there doesn't mean it's functional. We oftentimes err on the side of caution and assume it's not functional. And actually, that's what I was trying to tell you with my little young man here. I don't really care right now if it's functional or not. I'm treating him as if it's afunctional because he's got other reasons to do so. Okay. All right, so sepsis. What is sepsis? We're going to move on and talk about infection. So sepsis is just a fancy word that means there's serious infection from bacteria in the blood. So generally, to make a diagnosis of sepsis, there has to be some sort of bacteremia, which means bacteria in the blood, and that's grown out of a blood culture. It's not always true. Sometimes you have a child who comes in, fever of 102, they get an antibiotic before the blood culture is done, and so you don't always isolate the bacteria in the blood. But the criteria, when we think about it as physicians, is that there's infection from bacteria in the blood. And of course, as I mentioned to you before, if there's no neutralizing antibodies, something to prevent it from invading tissues, then that bacteria in the blood can invade tissues. And so it can invade your lungs, pneumonia, can invade the meninges, the CNS, central nervous system, to get meningitis, and can generate a bone infection. And these are really sick children, and of course there's a risk of death if not promptly recognized and treated. So how do you recognize it? And we usually say, look, we want early signs, so come in if there's fever. And that's because you don't want to wait until there's late signs. This is too late in the game. This is a challenge for you guys, I know, because your kids are going to get fevers from other reasons. They're going to get viruses. They're going to get really innocent colds that are going to give them fevers, and that's a mess. And I just apologize in advance. The best part is that because the immune system is generally working the way it's supposed to, that's going to get better over time. So like all children, whether they have functional spleen or not functional spleen, you know, those infections are going to be less. Some of you may choose to keep them home during the early time periods. There's some wisdom to that, but they're gonna get those fevers when they go into kindergarten. So you may be postponing them. Are there reasons to do that sometimes? Sure, and that's something you'll have to balance in terms of your family, but don't let anybody put you down because you have to go and work and you have to put your child in daycare. Don't let anybody give you a hard time, right? Because sometimes it's just a function of your family, and you can just tell them, if they tell you you're making a dumb decision, well, guess what? Your kiddo is going to have all those infections in kindergarten. So that's a challenge. So we really want them to come in, and in particular, so kids who have fevers don't look great, right? So the first thing, if your child has a fever, is, okay, document the fever. And actually it's somewhat helpful to give a little anti-fever medicine because they look terrible when they have fever, right? So here's a little trick for you. Give them a little anti-fever medicine and then take them in. And because if they perk up when the fever goes down, we worry a whole lot less about these things, and when they are not febrile, they don't look this bad. So when you're febrile, you don't look good, lethargy, right? So you don't look good when you have a fever. You don't feel good, but when the fever comes down, the kid perks up and starts active. So go ahead and give your anti-fever medicines at home. Tell your doctor the kid was burning up. Just tell them that. The kid was burning up. Hottest I ever felt my kid. I couldn't not give an anti-fever medicine. That helps them because then they're like, okay, they look better now. I don't think I'm in this late signs of sepsis at this time. And then you have a little time to get, you know, oftentimes they'll do like a intramuscular ceftriaxone in the office. They may hopefully get a blood culture and then keep an eye on you. But don't be afraid to give anti-fever meds, because when we see kids who are, I can tell you, if your kid has a temperature of 102 in the office and they're kind of like this because they have a fever of 102, you're going to get like the whole kit and caboodle, more than you want, really thrown at you. And you're kind of like, but every other kid had this virus and snotty nose in my family too. So just something to consider. That's how we think as pediatricians. We like to know what kind of breathing time we have. So, all right, so if you're at the point though where you've given anti-fever medicines, the reason why we don't want you to not bring your kids in is because if you start to see these things, poor urine output, collapse, lethargy, it's too late in the game. Now sometimes you'll have, you know, poor urine output because there's, you know, a gastro flying through your family, right? So there's other reasons other than sepsis for poor urine output. Dehydration is one of them, and it can be from things other than sepsis, so viruses can cause that. So these are not just in isolation, right? So in this setting of fever and chills, if we see these late signs, we kind of freak out. All right, what can family do to reduce risks associated with infection? Well, here's where we're going to get into some details, and then if you don't want to know, then just space out. So I'm going to review what data we have, and I'm going to review old data and then newer data. And the old data comes from children and adults who've undergone splenectomy. Well, that's not your kids, okay? But best data that we have in older individuals is actually in splenectomized individuals. So someone had surgery, they took it out. That's the most data we have on older individuals. So we know that in that population, your likelihood of having sepsis is extraordinarily higher. That's like 300 to 400 times higher than the general population. That's why we care. That's why we want you to bring your kids in when they have a fever. That's why we don't take it lightly, and it's such a nightmare for you. So that's the background of this. So, and then the second sentinel study was published in the 70s, and this was in children with sepsis and congenital asplenia. And they found that 27% of 59 children with asplenia and CHD, which is congenital heart disease, so all these children in this particular study had congenital heart disease, that it was really high. And they compared it with others that had congenital heart disease and no asplenia, and it was significantly higher. And the organisms that grew were different depending on the age. So if they were less than 6 months of age, these were the organisms. These are what we call enterobacter. They're things that are in your colon. They're poo bugs, right? So E. coli and Klebsiella, but they can get access to the blood if you're a baby, itty bitty. And you can appreciate that these would be babies who would be having a lot of hospitalizations anyway, right? Because of the congenital heart disease. Greater than 6 months of age, here's the two that we talked about. It was pneumococcus and Haemophilus influenza B. But you know what? We didn't restart routine vaccination for either of those at this early time period. So this study doesn't help us either, because we didn't have the vaccination approaches that we have now to boost the immunity to get ahead of the immune system against those nasty sugar-coated bacteria, strep pneumo and Haemophilus influenza. These E. coli and Klebsiella are not sugar-coated bacteria, so that criteria doesn't apply, but antibodies are generated that neutralize them, that prevent them from invading. And so the recommendation in 1977, which has stayed the same so far in the United States, but is maybe changing, was that children would be put on lifelong penicillin. So what is the risk of infection now in our current vaccination area, which includes these tricky, wonderful vaccines that include the sugar plus the protein, the conjugate vaccines against pneumococcus and Haemophilus influenza? So there was a study done, very few patients, unfortunately, 29 patients. This puts you into perspective with what Dr. Goldberg was saying. Trying to recruit 300 patients with rare diseases is hard to do, right? This was a retrospective study also at one center in the United States. These were children who had asplenia and polysplenia. A couple of them had infections that preceded the vaccine recommendations, but most of them were post-vaccine. And here's some discouraging news. 24% of those individuals had sepsis. That's not different from what I told you on the previous slide, right? I told you it was 27% on the previous slide. Why is this not different? We started vaccinating. Well, you have to kind of think through what is different at the time. This was 1999 to 2009, this 10-year period. Surgeries, more hospitalizations, more children surviving. So the one thing you would naturally look at is, are the infections the same? Are you now no longer having the strep pneumos? And are you now suddenly having more sepsis that is related to more hospitalizations, more interventions, more surgeries, more survival of kids who might have not survived before? So you have to take all of this with a grain of salt. This is called bias. When you look backwards, there's always bias. All right, 6 of the patients had actually developed sepsis while taking recommended preventative antibiotics. Why would that be true? The reason is because our bacteria are resistant to the antibiotics that are being recommended now, right? And that wasn't necessarily true back in 1977. So there's challenges here. E. coli, for example, is often now resistant to amoxicillin. Certainly strep pneumo, we have to use high dose amoxicillin, or we couple it with and use it as augmentin, or we use other antibiotics because of resistance. So that's kind of a bummer. And then most importantly, in this population of these 7 patients, 62%, so it must be like 4 out of the 7 or 5 out of the 7, they were actually sepsis events in the hospital. This is in contrast with the previous study where these were mostly community acquired, okay? So this just tells you that this population is a little bit different than what was reported back in 1977. Although the rates were the same, the infections were in a different environment. Importantly, no cases of pneumococcal sepsis occurred after the introduction of the conjugated pneumococcal vaccination in the pediatric vaccine schedule. So the organisms have changed after the vaccines in this study. And unfortunately, still bad news, bacterial sepsis is associated with a 44% mortality rate. So that's not good news. What is the risk for infection in another study? This is an interesting study to me because it was done in Taiwan. It's a totally different bias in their population. They had a lot of children, and they included 95 children with heterotaxy syndromes and congenital heart disease, and then they also interrogated 142 other kids, kind of equivalent, who were going through heart surgeries in the hospital, et cetera, but without asplenia. And what's different about Taiwan is there is not a recommendation for prophylactic antibiotics. They use on-demand antibiotics only, okay? And they do have the same sophisticated vaccine prophylaxis that we recommend here. So it's interesting, it's almost like a comparison group for the study I told you about where we did use antibiotic prophylaxis. In the previous study, 80% of the patients had been using antibiotic prophylaxis as recommended. So what they found was that more patients with asplenia had community-acquired sepsis. So 10 out of the 95 patients, and here they broke it down between hospital-acquired and community-acquired also. And I'm going to spend most of the time talking about a community-acquired. Interestingly, when they compared the heterotaxy group to the other congenital heart diseases, there was no difference in the hospital-acquired infections. They were high in both of them. So the presence or absence of a spleen doesn't mean much in the hospital setting. It still means something in the community. So here's the data. So community-acquired sepsis, they had 0 in the congenital heart disease group without asplenia and 10 out of the 95. And the annual rate was really high in the less than 2 years of age compared to after 5 years. So this is a group that did not get antibiotic prophylaxis. And as expected, the less than 2 years of life where you can't fully vaccinate against pneumococcal 2000, right? Because we have pneumococcal, we have Prevnar 13, but there's so many more bacteria than those 13, right? So that's why we use antibiotic prophylaxis in this very early period where your body cannot make immunity against sugar-based bacteria. We don't have perfect prevention from our vaccines. So it makes great sense to use prophylaxis in this less than 2 year period where they're seeing more. And then it starts to go down. And then after 5 years, it's really far lower, which is good news. So what's interesting is that 3 out of the 10 patients, this addresses your questions, 3 out of the 10 patients suffered from their infection had a spleen identified on a previous study. So we planted that question in the audience. And then of the patients, there were actually 3 that had pneumococcal sepsis. That's discouraging, you guys, because this is vaccination time. And 2 had only had the sugar-based vaccine, so not the conjugate. But 1 had the conjugate vaccine, and guess what? They had Prevnar 7, and they had an infection with something that wasn't in Prevnar 7. So we need Prevnar 2000, right? But it gives you a flavor of why, it's helpful to stay up to date with the vaccinations as well. And all of the pneumococcal infections were resistant to penicillin. Go ahead.
I'm pretty sure, though I can't quite remember. It's
Yeah.
been a while since I read this paper.
Yeah.
When you say asplenia here, I think they were lumping asplenia and polysplenia together, right?
Yeah, they had both polysplenia and asplenia in this category.
It was like a very small count for polysplenia.
Correct. There were very few with polysplenia. That was not true of the previous study I showed you, where there were far more with polysplenia. Actually, percentage-wise, only percentage-wise. But in this particular group, you're quite right. The majority of them had asplenia rather than polysplenia. All right, and here we have bad news. Hospital infection is 33%. That's the same as the one I told you about, right? So the bottom line is that we're not doing a great job in our hospitals, and it doesn't matter whether you have a spleen or not. So we got to make some progress here. And we're really paying attention to that at Children's. So in the hospital infections, asplenia was irrelevant, and it was a very common cause of death for these children. If they were going to die, they're most likely to die of heart disease, but the second highest reason to die was from infection, and often associated with surgery. No surprise, right? That's a problem. All right. So steps families can do to reduce risk. Now, in light of what I've told you, what can we do? All right. Guidelines we all agree on. Vaccination should include conjugated vaccines, yearly influenza. If you want to see the current recommendations, they're different for asplenia, and your pediatricians may not know this, okay? So this is important. Your pediatricians may not know that, in blue, children less than 19 months of age, we actually recommend that you give meningococcal vaccines. That's not true for the general population. That's specific for asplenia. And the CDC website lists these, and you can just print them and bring them to your pediatrician. That's what I recommend. They also recommend on the CDC that in addition to the typical booster series of Prevnar 13 that all kids get, that a single revaccination with the sugar vaccine be done. Why? Because we have Prevnar 13, we do not have Prevnar 23. And pneumococcal sugar-based vaccine, pneumococcus, Pneumovax, is actually 23 different ones, but it's not as good a vaccine. So that's not the only one you should get. It's not as good, but it's a little bit better. So the combination of the two is a good idea. However, I have to tell you that your kids, when you get the Pneumovax, they're gonna get a reaction to it because it gets a giant big red arm, and I see moms shaking their heads, and so I just apologize in advance. It's still the right thing to do, but your pediatrician may not know this. They're gonna get a big old red mark, and it may go from here all the way down to here. And they may even have a little bitty fever with it, okay? So, and it's just the body doing what it's supposed to do, generating an immune response, but because it's already seen a lot of those different sugars before, it gets excited. It's like doing what it's supposed to do, and it makes this nice little local inflammatory reaction. You can celebrate that that's good news, it's doing what it's supposed to do, and then curse me at the same time, and I will take all of it. So.
I'm sorry, you meant the 23 gets the big lump, right?
Pneumovax in this setting, yeah. All right, and then children who receive 2 or more doses of Hib before 12 months should get a 3rd dose. But guess what? All of your kids did this already. So that's in yellow because it's not different from the recommendations. Okay, guidelines we all agree on. Patients need to seek urgent medical care at the first sign of fever. It says or illness. Well, I know you're not going to come in the first time your kid throws up, right? That's not the right thing to do. So you're going to generate a measure of this, especially if every other person in your family was vomiting. That's helpful, right? It's really nice when all the other kids vomit and get better in 24 hours. But if there's fever, and then you got to bring your kids in. All right. And then I'm a big fan of the approach of considering whether a family can have on-demand antibiotics at home. This is a conversation you can have with your pediatrician, but I don't know why you couldn't have on-demand therapy at home, so that at the beginning of a fever, high fever, you think, oh my gosh, this is bad, I know I need to go to the hospital, you could give the antibiotic at that time. There are a lot of people who would disagree with me. So this is not a universally accepted to have it in the home, but where people would agree is that child needs to be evaluated immediately, and then some people feel strongly that it's a pediatrician who should stick them in the leg, but I don't know that I feel as strongly that it has to be the pediatrician to stick them in the leg, because you could bypass the pediatrician at 8 o'clock at night by giving your dose of high dose amoxicillin or high dose Augmentin, and then going to the ER, and then you're still in better shape because you've got antibiotics on ahead of time. Yeah. So if it's done immediately, it may not. It doesn't matter to me because I'd rather have your child be healthy and alive. I don't care.
Because we just have had several patients lately that have had false negatives,
yep,
and they are not being treated as having sepsis.
Right. But if the antibiotic I gave got rid of the bacteria in the blood, your child's still well. Doesn't matter how I got your child well, whether it's a child who's well with a bacterial infection or not. Do you see what I'm saying? Healthy child, to me, trumps whether my test works or not.
No, I see a need for immediate antibiotics,
yeah,
but we just have seen a lot more cases where they are getting a false negative, and then that one dose or that small dose of an oral antibiotic is not going to bridge them through, and that is back to vengeance. I mean, it's
Okay, so then the problem is actually the doctors, and I'm okay with embracing that problem. And you just need to train your doctors that way, right? You need to ask that question after the antibiotic's been given. And then what they'll do is they'll go back and they'll be like, golly, that white count was extraordinarily high. That's not good. And that we're smart, we do that.
But as an organization, we do recommend that each of you have that conversation with
Yep.
your doctors.
Yep.
The fever and that so that you are all on the same page.
And it matters where you live, right? If you live an hour from a very good medical center, I hope you don't, but if you do, that's okay too. That's the child I really want to make sure especially I get. You know, I don't care if you're walking distance to the ER, it may be better to go get that blood culture drawn, right? But if you're an hour away, I'd rather you have it in your home. And there are some families who, I'm sorry to say, they shouldn't have it in their home because they would give it every day just to be sure. You know, I don't want them to do that either. So it's not a universal, but it's something that you should have a conversation with. All right. Use of high-dose antibiotics prior to presenting, we just talked about this, should be decided. All right, guidelines that are less clear. In the United States, American Academy of Pediatrics suggests still lifelong antibiotic prophylaxis using penicillin in patients with asplenia. In Australia and the UK and Canada, there are different recommendations, so this is obviously not simple. So you can either do lifelong or at least below 2 years of age. That makes sense now because we just reviewed data showing that the rate is significantly higher, and we know children can't respond to sugar-coated bacteria at less than 2 years of age. So now you understand the recommendation that they have it for at least below 2 years of age, and of course are followed by emergency or standby antibiotics if no severe infection occurs in the first 2 years. Middle ground approach that I feel I'm growing in my comfort with as an immunologist is that, one, you can receive daily prophylaxis until at least age 5, and that can be penicillin or amoxicillin. Amoxicillin is a reasonable choice. It tastes better. There are children who we may consider to do it longer. Those are kids who've had significant infections, or we've had an evaluation of their immune system and we know that there's something else wrong. There's another piece of the immune system that isn't working as well as it should. So some children should have prophylaxis for life or to 18 or whatever. So it's not a one-size-fits-all approach. And then we talked about amoxicillin being palatable. Okay, how are we doing? I like this paper. It was published in 2012, and it's just a teeny simple little paper, and it asked, how are we doing? It was a Massachusetts healthcare system, Boston healthcare system, where they said, how many of our patients actually comply with recommendations for this? And they created a registry, and then they started calling, they educated physicians, and then they started calling families and emailing families and asking, well, how many of you guys actually follow these recommendations? So they assessed whether the individuals were vaccinated, whether they had on-demand antibiotics, whether they had knowledge of the guidelines, and they were interrogating physicians and children. And then they reassessed to see how they had done with this maneuver. And so at their baseline, they had 75 individuals that they were generating the registry from. And then they assessed how many were receiving all interventions. And as you can imagine, at the beginning, it was 2%, 2. So not so great. This is why you guys exist, right? In my mind, is to help educate and inform other families and physicians, because not all physicians were obviously aware. So they start educating physicians, and we go from 2 to 20%, so a 10-fold increase in compliance. And then when they reach out to you guys, then we get the rest of the way, right? Because really it's educating families that makes a difference. That's why I say yes when you ask me to come and talk here, because I need you guys to go tell other families, hey, have you gotten your vaccines? Hey, do you have on-demand therapy available to you either at the pediatrician's office who's close by or in your own home? And hey, are you talking to your pediatrician about this every time you go in? All right. So the next steps for you guys, get the information you need, get to know the guidelines, go to the CDC website, go to the American Academy of Pediatrics, come to a talk, learn how I think about things, discuss with your pediatrician whether your child's up to date on vaccines per these guidelines. They may look like they're up to date on the typical child guidelines, but the guidelines are slightly different for kids with asplenia, and they may not know that. Pediatricians can't know everything. Get an annual flu shot. Discuss antibiotic prevention and on-demand therapy at every visit with your pediatrician. When I say every visit, I mean annual visits generally. And make sure you're bringing your kids in for annual visits. If you bring them in for a broken elbow, don't ask them about the antibiotics. And then I think it's really important to have a written plan in place that you would give all caregivers. So if you, by some stretch of wild fortune, get to take a vacation and you leave your child with grandma, make sure there's a written plan. If you have a child who's in a daycare, especially an in-home daycare where it's not like state guidelines here and this and that, make sure that your providers have some written guidelines that you yourself follow in your family. So I think that's really helpful. What to do with fever, chills, etc. I think there I'm going to stop and answer any other questions. Yeah.
So we've seen so many doctors who live in law, and what do you suggest? Because we've found that some doctors are very nonchalant about the whole asplenia thing,
Right.
and asking for a fever, something
Yeah.
like that, and we're just kind of like, whatever.
Uh-huh.
And then we have those who say, oh my gosh, it's a big deal, and
Yep.
it's like they're freaked out about our child.
Right.
And so for kids with heterotaxy, at what point do you say, okay, my pediatrician only knows this much?
Yep.
I need to get a referral to see if the immunologist can be followed by somebody that's more specialized.
Right. So the question is, when do you fire a pediatrician? Don't fire your pediatrician. All right, no, that wasn't the question. You were much more fair than that question implied. So I think the first question is, should you fire your pediatrician? And then the second question is, are there additional people you could put on your team so you don't fire your pediatrician? And I actually favor the latter approach, but I actually favor an approach that does three things. One is that you understand the limitations of your pediatrician by having a conversation with them every time you bring them in. You can just ask simple questions. Hey, I learned that there's different guidelines for vaccination in kids with asplenia. I printed them up for you. Would you like to see them? If you have a good pediatrician, they are not going to be threatened by that. If they are threatened by that, you need to fire your pediatrician because you are a consumer and you should find somebody. And it may be that you find a family doctor who's just going to listen to you differently. And they may not be associated with any fancy medical center, but they're going to spend the time listening to you and take that sheet of paper and read it and say, we didn't do meningitis vaccination for your child. That's the pediatrician you want. Someone who's going to look at data with you, who's going to be humble and not, assume they know everything. It's really helpful to have pediatricians who say, I don't know, but I'll find out for you, right? Those are good pediatricians. You just want to avoid the ones who say, I don't know, I don't care, go to another pediatrician. You should, right? If you get that kind of affect from your pediatrician, you should fire a pediatrician. In most situations, I think that you don't need a super specialist. I think that you can find a good pediatrician or family doctor in your community that you can work with, especially because you're going to have a cardiologist at your disposal who's going to be able to be a backup person for you. And so if you feel like you're not getting anywhere, you can have the cardiologist talk to the pediatrician. There's nothing wrong with that also. You can have your cardiologist develop a fever plan that you then take to your pediatrician. So there's so many different ways to do this. And you guys end up developing a lot of doctors. You don't need more doctors in most cases because it gets more muddled as you go. You just need doctors who are willing to talk to each other. So try not to fire your pediatrician unless they're awful. Do try to empower your pediatricians to have more information by either looking at what you bring them or talking with the cardiologists who are often much more knowledgeable. And then in the setting where you have a known episode of sepsis with your child, that's when I would recommend you get a third person involved, a consideration of the entire immune system. And most likely everything's going to come back completely normal and it was just bad luck. But what if it isn't? And there's some other little piece that, because 27% or 25% or 24% or 7% of children with heterotaxy develop sepsis. That means that somewhere between 75 and 90 did not. So there's something different about that 10%. It could just be bad luck, but it may be that it's not just bad luck. Maybe there's another part of the immune system that doesn't function as well. So maybe they need an out-of-the-box approach. Maybe those are the kids who need prophylaxis for life. And that's a conversation you can have with a thoughtful immunologist. An AI specialist oftentimes will have that conversation with you as well, allergy immunology specialist. Great question. What other questions?
So we all know people that are opposed to vaccinations.
Yeah.
What is your recommendation on how to handle that social situation for us? Is it really we need to keep our kids completely away from these children, or what is?
Okay. Wow, that's such a loaded question. I really liked this. What was it? Was it Jimmy Fallon or one of the late night hosts took this on the other about 6 months ago? Oh man, I was posted it to Facebook, and I was really happy to hear it. So I totally get some people's hesitation to vaccinate, right? So, and our culture is not driven to look out for the benefit of everybody. Our culture is driven to look out for benefit of uno numero, right? One person only. So it's not too surprising that we are seeing this trend. You can't isolate your children you can't isolate your children completely. The good news is that the one vaccine that most parents refuse if they're going to is MMR. MMR does not put your child in particular at increased risk. So that's one way to answer the question.
We know a lot, I'm sure in society. I know a lot that refuse all of them, and they're like, well, my kid's healthy.
That's a problem.
Yeah, and so
It's going to be primarily a problem with Haemophilus influenza B, because before this movement, we really have seen eradication of Haemophilus influenza B as serious bacterial infections in young children, and I'm nervous about Haemophilus influenza B. And strep pneumo for the same reason. That's the irony, is we get better and better. And the problem is that I think we haven't done a great job of educating families what to expect about vaccines. So for example, not all vaccines are the same, right? So it's really important to me that we never stop vaccinating our kids against strep pneumo and against Haemophilus influenza B. These are amazing vaccines. And not all vaccines are going to be benign. I just told you that if you follow the recommendations that I have to give your child a Pneumovax, you're going to get a whopping red mark on your arm. What if your pediatrician told you that ahead of time? What if they said, you know what, there's a good chance that this MMR vaccine is going to be associated with a fever ahead of time. I still think it's the right thing to do. Wouldn't you have a different point of view? So I think we need to be, as pediatricians, kind of transparent about there are side effects and risks of everything, but then we still recommend it for the good of all of our kids. It's a challenge. Maybe not the daycare you want to choose. Well, but my point is, you can kind of, in some ways, choose your environments. But the public school system is a problem, and well, don't get me started. I think you should not be allowed access to public school if you are not vaccinated. I think we have the right to say you have to have your vaccines to come to school. Anyway. Should we go march? Let's go take Smale Park. Go ahead.
It's about, and I don't know much about this, but there's some folks that have talked about getting tested to see the vaccinations, how effective they are in our kiddos, and I don't know if it's different with asplenia or heterotaxy. Is that how necessary do you feel?
So that's part of seeing whether vaccines are effective, is part of looking at the entire immune system as a whole. If your child has been coasting and cruising and not having a lot of infections or serious infections, I don't recommend you go there, because you have lymph nodes and tonsils and adenoids. And so, but if your child is the one who's like, okay, we're on our 4th set of tubes, or we've missed 50 days of school because every time they put them in school, they come home with a fever and snot and everything. Maybe. So it's really individual based on, but if your child is doing well and doesn't have a lot of infections, don't go there, it's not necessary. But it is necessary for other kids where there's, and then that child becomes no different to me than the next child who has too many infections when exposed also. And we just do a very simple, brief immune system evaluation, and then we come back and give you reassuring news that says it's all normal, check the box, cross me off your list and go, with a little bit more peace of mind, so.
I just want to put out there, there's one thing that, and now in my center, the best person that's been to handle this with the person has been hematology. What the most valuable thing I got out of visiting hematology was that she put an alert on our medical records that said, if he comes in with fever, cultures, CBC and antibiotics.
So that's a written plan.
Exactly.
Yep.
And it's in there and it's top of the alert, and that was the most valuable thing. We had went in for fevers before and I was like, I don't know what to do, let's do an x-ray, let's call cardiology. After we saw her, it was totally streamlined. Best decision we made was to get that.
It's great feedback.
Same thing for us. Immunology, we did was a one-time visit. We
Yep.
got our fever plan written up. It's in her chart.
Yep.
And that was
And it doesn't need to be something fancy. So in the electronic medical record, we all have problem lists, and so it just needs to be part of the problem list. Asplenia needs to be part of the problem list, and then a little blurb after it that says, if patient comes in with fever, please do blood culture and parenteral antibiotics. And good, thanks, good feedback. Anything else? Yeah. That's a good question. So there's nuisance infections and then there's serious infections. So I love the fact that most of the referrals into my practice are for nuisance infections, because then I get to tell parents, guess what? Nuisance infections, and lucky for you, you haven't had severe ones requiring hospitalization. It is not the wrong thing to do, though, as a parent, to say, I'm nervous, I have more than I think my child should have in terms of nuisance infections. Can you just check and then reassure me? And oftentimes that's as simple as reviewing data that already exists for that child in the chart that you weren't even aware had been evaluated along the way. So that's one thing also. Sometimes that data is in there. And because the first thing we looked at is, are the white blood cell counts normal, right? And that's part of every complete blood count. We already talked about that. So you can just simply say, are the white blood cell counts normal? And if you find, oh my gosh, my kid's white blood cell counts are not normal and sick all the time, then, that's something to think about as well. So it's a good question.
My other question is, if your child was in a collection and then they get their infection and they have to go to hospital.
Yeah.
So my daughter is always going to stay on the classes because we always get that computer diaper.
Yeah, you do not need to stay. It depends on the antibiotic that they're using, and you should ask that with every antibiotic. So in the case of if they're on Augmentin for ears, they don't need to stay on the antibiotic for prophylaxis. They can just stop it and then restart it. But if they were on Bactrim for urinary tract infection, you might argue that they could stay on it. So depends on the antibiotic. All right, very good. Thank you.